I'm doing the Rocky dance. We're fighting. Okay. Has a injury to his back, which he sustained at work. All right, we need to orbit a little bit at 5-1. Look at the sacrum. And we're getting ready to do the Duke laser disc repair. Not much. Orbit is usually just a degree, not like 5 degrees. All right, that's better for sure. That's better. Right? Or am I imagining it? No, try the other way. I could be wrong. Let's see the other way. That's actually better. I apologize. So let's just leave it there. All right, so the first thing we have to do is, of course, we want our patient to have a surgery that is nice and sterile. We don't want to create any new problems. So we want good aseptic technique, and that's what we've got, okay? Sterile environment. Okay. After that, we of course want a safe procedure where we don't create any new problems for our patient. That's our goal. Shot? And our goal today is to fix 2 discs, the L45 and the L5S1. Shot? So my job is to get down there safely so that we can do that. Shot? All right, I think we need to fix the pedicle of 5. So it's very important that we do sterile prep and drape, which we've done, and then the next step is to get the navigational system set up so that that looks actually better. Maybe you need to bring the whole thing south. Are you comfortable, sir? Are you doing all right? All right. Just hang in there. Everything's fine. Shot. Hey, not bad. Now the reason for this steep angle here is quite literally that he has a very high pelvis. Are you okay? Yeah. So what I mean by that is this bone back here, called the iliac crest. Okay, this hard bone, the skeleton bone back here is really high. And then it's high on the other side too. So if I try to go in lower, which I want to, by the way, I can't because it's blocked by his bone, his body. All right, we're off a little bit on the wag. I don't know if he moved a little bit. Probably just about a degree one way or the other. I don't know which way. All right, let me have control of the wag. Shot. May have overshot. Shot. That's well. Give me a 1 degree orbit, one way or the other. All right, shot. Perfect. Actually, that's really, really good right there. Lock it. All right, wow, that's better than I thought it would be. You're doing good, sir. Just bear with me, okay? Huh? Of course you do. You can tell me to stop and I'll stop and leave you alone. But you want to get out of here and not have to ever come back, Shot? That's our goal. Fix you and once and for all. You had surgery before, right?
Oh, yeah.
Who did your first surgery? Who?
New York.
Oh, in New York. Are you comfortable? Are you feeling any pain or anything? Nope. Good. We're trying to keep you as comfortable as we can while you're awake, and then I'm going to put you to sleep in a few minutes, okay? I have a feeling 5-1 is not going to be painful. You too? Right? But there is a herniation on the MRI. So this patient has, how long have you had lower back pain for? Since 1999?
Yeah.
So 22 years. Correct? All in this area? And no one's ever fixed it for you? Huh? I couldn't hear you. I did it once. Okay. All right. So why are you having surgery today? To fix your back pain, right? All right. So that's what we're here for. He's got 2 discs that are bad. The 4-5 is the worst. You can see it. See that, Shot? Where's our blood pressure? Yeah, let's try to. I really don't want to have to keep saying it. Please. Automatic. Every surgery. Shot? All right. So I'm going for the L45 next. And sir, are you comfortable? Shot? Okay, good. Shot? Now the L45 is honestly going to be really tough, but I think we'll be able to get it. Shot? Are you feeling anything, AP? Nothing down your leg? No? Okay. So we've made our incision. We've got 2 needles going. We're about to get into the 4-5 disc through the tear. I just want to make sure it's looking good, and it is. Let's go back to a lateral. So the start of the surgery is all about navigating from outside here where we are to getting into the disc that we need to fix. That's really what the goal is. Shot. Shot. You're doing really good. You're doing really, really good. We're almost done. I'm going to put you to sleep soon, okay?
I don't want to do good. I want you to do good.
Oh, yeah, I'm doing fine.
Okay.
Yeah, but you're doing good. Like, we're doing good as a team. Okay? All right. Are you comfy? I'll put this back. All right. I just would be very surprised at this one. Now, the MRI report says his pain is down low, but the MRI report said L5S1 has a herniation, okay? I have to say, it looks small to me, but it's possible. Do you feel anything? No pain? Sir? Nothing, right? Nothing? No pressure, no nothing. Shot? Nothing. Or do you feel something there? Anything? Do you feel pain there? Huh? Now? Okay, so 5-1, negative for pain. just as I suspected, but it was herniated on the report, but it was a bulge, so it wasn't a big one. To me, it didn't look that bad. So, do we have more dye? Or is this it? You have a full one? I have a feeling it's going to leak out pretty bad. Are you comfy? So the L5S1 disc, we had no pain. Just zero. L45. This thing is completely gone. Are you okay? How bad was that?
Not too good.
Give me a number. What's the highest it went?
Oh,
Huh?
8 and 9.
9/10. We go with the highest number. Was that where you typically get your back pain? All right, folks. You saw it firsthand. You can go to sleep now. We're going to give you some medicine. I want you to count from 1 to 100. When you wake up, that pain will be gone. That's what we're here to fix, okay? Count from 1 to 100. Yes, sir. Go to sleep. So amazing, right? Like we had to test L5S1. I put the dye. No pain at all. We're leaving that alone. You don't operate on a disc that isn't painful. L45, there's no disc there. It's totally collapsed. And look at that. 9 out of 10 pain. And you heard the response. That's his typical pain. So, great result. Great result. I'm very happy. That means that pain will be gone today. When we're done with surgery, it won't come back. Sweet dreams. Huh? Yeah. You're right. Go ahead. Shot. Shot. And just put it on. And a little pressure as you pull out, and you'll feel the resistance, okay? It's about this much pressure as you pull out and pull it out. Yeah, pull the whole thing out. There you go. Perfect. See? Nice job. Okay. Yep. All right. Is he asleep? Let's just make sure the guide wire is where I want it. At L45, we are not treating the. We're not going to do the laser at 5-1, but we do everything else. Shot. But what a great experience for everyone to see the difference between a disc that is painful and a disc that's not painful. And it was obvious, right? Shot? Okay, I think that's good. And how I got it into this disc, I don't know. So even though 95% of the disc at L45 is gone, it's collapsed, he still has pain there. And this is what baffles so many doctors and scientists. They have no idea. How could a disc that has no disc left be painful? And the answer is simple. We're not doing 5-1. We did a discogram at 5-1, but there's no pain there, so we're not treating it. Because the disc is well preserved, there's only a small bulge. I was questioned, maybe it's hurting, maybe it's not, but it's not. So we don't treat it. And it's not causing any ridiculous symptoms. So we're only doing 4-5. But you see there's no disc at 4-5, it's collapsed. So why is it so painful? It's because it's the tear in the annulus in the back of the disc. It's always the same thing. It doesn't matter how collapsed the disc is. If there's a tear with inflammation in the tear, that's our target. That's where the back pain comes from. And that's what we're going to fix today. So he's going to get the relief that he was hoping for with the surgery, but he's only going to have laser surgery done on one of those two discs. And it's going to be the one that we all kind of didn't really expect. I mean, you know, I expected it, but when you look at it, you see how degenerated the disc is. You think maybe there's nothing that can be done. Shot. All right, so here's the hard part. He's asleep. Yes. This is going to be painful because this is the sensitive area of the disc. So when he feels this thing touching it, the back of the disc where the pain's coming from, he's going to want to move. But he's not moving. He's doing great. So our anesthesiologist is amazing. You should come work here full time, you know. Doctor, you should come work here full time. Why not? Oh, it's far? So move. Move here. Move here. What's wrong with moving here? You can see the disc opening up. You don't want to move to Vieira? Where do you live now? You're talking about Ocala? I've been to Ocala many times. Ocala I like, it's peaceful. Have you been to Amrit Palace? No? Indian food there? When I was in Gainesville back in '97, I used to go to Amrit Palace to eat. It was the only Indian restaurant there at the time. There was nothing else. I was there about 6 months ago. My son went there for a race in Ocala, and we went to Amrit Palace for dinner. As a matter of fact, my nephew is starting school at UF. No, undergraduate. He's only 17. He's starting tomorrow. He leaves to go move in at UF. So, shot. So I'm getting this whole tube into the disc. You can see how the bones have spread apart. You see that? They're spreading apart because the patient is comfortable, and yes, there's a reflex pathway to shot to the paraspinous muscles. When there's pain in the disc, the patient will feel the pain, and there's a reflex arc that's subcortical. It just happens at the spinal level, and it causes the paraspinous muscles to contract a little bit, but you can feel he's very soft. He's not tight. If he was awake, he would be in so much pain. He'd be arching his back, tightening his muscles, and it perfect. And it would be clamping down. That's propofol. It would be clamping down on the disc. So, because he's comfortable, he's not feeling the pain, he's not tightening up, I'm able to get this 7 millimeter tube into the disc space that's normally 3 millimeters. All right, we're going to get in there and we're going to find that bad part of the disc, the annular tear, where all the inflammation and granulation tissue is. And then we're going to get out. We'll be done in about 10 minutes. All right, beautiful. Let's see if we can find that area I was talking about. It's going to be red and inflamed. All right, grabbers.
He's coming.
Oh, really?
Yep.
Thank you, Luis. You did a great job today, by the way, by yourself. We have 2 people out sick today, and they're not COVID. Laser, whenever you get a chance. We've had just the flu going around, you know? And the people have been testing for COVID negative, but still there's the flu. As a matter of fact, we've had some GI issues, GI viruses, gastroenteritis. Not me, thank God. Here, go ahead. Anybody know what the most common cause of viral meningitis is? Huh? No, meningococcal is very rare. Thank God. The most common cause of viral meningitis is enteroviruses. So you get meningeal findings, headaches, neck pain, stiffness, and of course diarrhea. So, have you ever seen meningococcal encephalomeningitis? Have you ever seen it?
No.
I have once. In Shands Hospital, Gainesville. It was the worst day of, I think, in medicine I've ever seen, ever. Just the most horrific experience. in my entire medical career of 26 years. A young girl, 16, 17, college freshman, she came to the ER with rash and headache, vomiting. And within 2 hours, she had disseminated intravascular coagulation, and she lost blood supply to her right leg. And I was an intern. This was '97, and I was on the plastic surgery team, and we were on call for amputations. So we took her to the OR to amputate her right leg because it was dead. And we were talking about how bad it was. And I was with the chairman, Dr. Caffey, amazing man. And he had pulse ox on the other extremities. And as we're prepping her, her left leg went dead. She clotted her left leg. So then she became a bilateral amputation at 17 years old.
Within hours?
Within 2 hours of presentation to the ER. And about 4 hours from symptom onset. So as we're getting ready to do both leg amputation, she lost her arm pulse. And then the other arm. And then she died. Right in the operating room. Right on the table, she coded. It was the worst experience in my entire career. Just the helplessness, the inability to do anything to save her life. It was shocking, staggering for me, you know? I mean, there were a lot of people crying that day. Yeah, we didn't even cut. We never cut. We were preparing, and it happened so fast. So fast. All right. Believe it or not, this little area right here is the whole source of pain. At least we don't have much bleeding this time. We're going to be done in about 8 minutes or less. Hard to believe that such a small little thing right there can cause all that pain, all that suffering in the back. And notice there's no disc left. You just have the pink thing is end plates. End plate, end plate. How's our irrigation pressure? Good? What is that?
Oh, the other one.
Huh?
The other one is good? This one is not okay.
Little bone spur right there. See that? I'm having trouble rotating it. That bone spur I just obliterated right there with the laser. That's a calcification inside the posterior annulus. I just have to be careful because we're just about in the foramen. All right. 5 minutes. 5 minutes, doctor. Do you have children in school?
They are last year since grade 5. They are just high school.
High school? In Ocala?
No, in Las Vegas.
Oh, Las Vegas. All right. Look at that herniation. Pretty cool, huh? Oh yeah. Yep, he doesn't like that because that's where the pain's coming from. Oh, we're done. I'm missing.
Lights on, please.
You want to see that? We should be able to see the nerve root here.
Thank you.
Scope off.
Scope off.
Yep, thank you. Good work, everyone. Yeah. Can't see. Just lay still. We're almost done. You have any more irrigation? Let me have it. Lay still. We're almost done. You're doing great.
You want to push her on this one?
No.
Can we turn off all the lights, please?
It's interesting. Where did I get you guys? Did I get you?
Ah,
Where?
just on the lid.
Huh?
On the lid?
On your lead? Oh wow. Over my shoulder?
Yeah.
Amazing. You did great, sir. It's all done. Well, that was interesting. That disc was easy, 95 to 98% gone, and yet still painful for the patient, you know? Amazing. Right? Just something, still a little left of it, and it's still just so painful. Thank you, Luis.
Thank you.
Yeah, I just think steri strip.
All right.
You should be fine.
Thank you very much.
Thank you. Good work today. Rita, you put your whole day in the OR, right? You survived. You survived. It went well. Patients did good. The second case, I just saw her. She's ready to go home, and she's probably already gone. She's doing fantastic. We'll have some good testimonials for everybody tomorrow. EBL, I'm going to say 5 mil. Where are my pages? All right, go ahead and type up your questions, folks, and I'll head over there. All right, so this should always be right here with this at the top. That's what I wanted, okay? So I just grab all these and I go. That's my stack. All right, thank you. Thanks, everybody. Great work. Jordan, great job.
All right, we're clearing for takeoff. There we go. This is how normally I'm running, about like this. I've got my arms out. Like I said, after about an hour, it was getting excruciating pain just going across my back. And he's fixed all that. As long as that's fixed, I'm ready to go. "30 years ago, I used to run motocross, cross country, did a lot of different things. But one of the biggest things I did was had a bad motorcycle wreck during that, and did an end over the handlebars, and basically planted my head straight into the dirt, and it jammed top of my neck, messing up 3 herniated discs. So I've been dealing with that for 30 years. Seems like a long time for me once you're living it. And finally, it just got to be so bad at the end, especially when I go to drive the RV. As soon as I hold my arms out for the matter of an hour, just the way the steering wheel is positioned on the RV, it just sends excruciating pain across my back. Gets down to my hands, where my hands are.
2, 1.
Hello everyone, Dr. Duke Magin, and we just wrapped up another lumbar Duke laser disc repair for chronic back pain. This patient's had back pain since 1999. That's 22 years of back pain since he injured at work. The L45 disc was pretty collapsed. About 95% it was gone. However, it was still painful. As we tested it, it had 9 out of 10 pain, and the patient almost jumped off the table when I put some dye in there. On the other hand, the L5S1 disc, the one below it, was not painful. And there is a tear and a bulge, but it's not painful at all, so we did not treat it. There's no reason to do surgery on a disc that isn't painful. That said, the L45 went well, and I feel like we got the pressure off the nerve, so his leg symptoms should get better. And we also got rid of the annular tear. We did a debridement and got rid of some herniation. So I feel really good about it. There wasn't as much to do structurally here. You can see me tugging at one of the pieces of disc material there, one of the little pieces of herniation that we shoved back in the disc when we put the dilator in. So I worked on that a little bit, and then I went on to debride the annular tear right there. You can see the laser zapping away at the 12 o'clock position. All that's all the inflammatory tissue we talked about earlier right up there. And that's what I cleared out, okay? So the patient's gonna do well, and he's gonna get out of here in about an hour. And we'll see this patient and the other 2 we did today tomorrow, and get some nice post-surgical video done, okay? Any questions? Have a great night. We'll see you tomorrow.